and I'm happy to talk about it. I actually changed all the slides from saying dissynchrony to asynchrony right near the end, because some of the articles that I was reading all started sort of transitioning to using the term asynchrony, but I think either is acceptable. So I want to go through the ability to essentially identify what the normal waveform should look like, because if you don't know what they should look like, then you can't identify when they look incorrect. And then we'll identify features of undesirable patient-ventilator interaction, which we'll call dissynchrony, with each component of the ventilator-delivered breath, and then develop an initial approach maybe to managing that asynchrony. So the problem is that there are a lot of patients in intensive care units that are on mechanical ventilation, but they're on it for different reasons. We've heard a lot about ARDS, acute lung injury, and sitting PEEP, but some patients have normal lungs and they're on mechanical ventilation just because they're not breathing right then, like during surgery, after surgery, from trauma and neurologic conditions. It's a lot different when you have a patient who has a progressive lung disease that winds up on the ventilator for some acute worsening, like severe status asthmaticus or interstitial lung disease or ARDS. So there is no magic answer for one mode or one setting that will be a cure-all for these patients. And so you have to know what you're expecting to do, know whether that's what's happening, and if not, identify what's wrong and how to address it. So first is identifying what you're expecting. And just for time, I'm going to skip through a couple of slides. If you work in different ICU environments, you may not know what you're expecting or how to figure it out because of what I call vent salad. Where I trained, we had two different brands of mechanical ventilators, and I think the fellows that train at Emory have three. They all call things different names, but they may be the same, such as where I trained, we used assist control ventilation, which was standard volume control. Volume assist, volume control, that's what I would call it if I have my own brand. But that's also called other names by other brands of ventilators. So there's some confusion just in the names. There are sort of standard accepted terminology, and I'll try to use those as I go through things. So the different phases of the ventilator-delivered breath I'm going to depict here, and it depends a little bit on the mode, but essentially each mode, the inspired breath should begin with the trigger, which is the line marked with red here. And that's when the breath begins. Now, trigger sort of means that the patient begins it, but it's not always began by the patient. The volume is then delivered through the delivery phase or the target or limit phase to some target, and then the ventilator cycles and the expiratory phase begins and is almost always passive, just depending on the patient's lung mechanics. Unfortunately, these waveforms that are schematics look really nice, but in the real world, it often may not look like this. So you have to know what they're supposed to look like. All right, so here's an example ventilator screenshot from a patient on pressure assist control. So it's a pressure control mode. And you have the top waveform is pressure, airway pressure. There's no esophageal balloon. The second is flow versus time, and the last is tidal volume. And on the left are some of your readouts, and on the bottom are some of your inputs. And so the next question is going to be about this screenshot. So, which setting on the ventilator screen determines how the ventilator cycles, or when the ventilator cycles? And the possible answers are A through E down at the bottom. So get your answer in mind. It may be hard to read on this slide, but A is the rate, inspiratory pressure, B, inspiratory time, PEEP, flow trigger. So we've got a good smattering of answers there. So The cycling is when the breath changes from the inspiratory phase to the expiratory phase. So the thing in pressure control that determines the cycling is the inspiratory time. And that's not the same setting that would be set on a volume control mode. Maybe most of us are used to volume control. So the correct answer on this one is C. Inspiratory time determines when the inspiratory phase is over, the ventilator cycles to expiration. So these are the three modes. I took the first one as the schematic that you saw earlier, but these are the three basic modes: volume control, and pressure support, that we most often use, and each of them have those three phases. In volume control, you set the flow and volume, and then those dashed lines at the top, which is the circuit pressure versus time curve, those dashes mean that it may vary based on the breath and the patient's lung mechanics. In pressure modes, you set the pressure, and what varies is the flow and the volume that's given with each breath. In pressure control, you set that inspiratory time, and that determines when the breath switches from inspiration to expiration. So that's the cycle. In volume control, the cycling is set with the volume. So what happens when things don't go as planned? So asynchrony or dissynchrony occurs in what, 10 to 88% of mechanically ventilated patients? How can that be? Well, it depends on how hard you look. And so the more you look, the more you find. Some studies use esophageal balloons to detect patients' efforts, and they're going to find more dissynchrony. Dissynchrony or asynchrony is associated with an increased work of breathing for the patient, perceived discomfort or anxiety, potentially actual discomfort and anxiety, but especially perceived discomfort and anxiety. Additional sedative use by the healthcare team, and prolongation of the mechanical ventilation time. The most common forms are ineffective triggering and breath stacking. So the problem is that asynchrony leads to anxiety in the patient and the person standing there watching them breathe, and that leads to probably more asynchrony if you are the patient, and hopefully less asynchrony if you're the doctor or provider that's managing it, but it can be tricky. So how do you identify that as asynchrony? Well, that 10 to 88% is probably because it's really obvious when it's extreme, but there is a lot of asynchrony that you'll miss if you don't look carefully. While I appreciate the earlier talks and think that using more data is generally better, the truth of the matter is we don't always have esophageal balloons, and we probably rarely have them. Those and diaphragmatic EMG are the gold standard for determining whether patients are having certain types of dissynchrony, but they're infrequently used. Even when looking, this is a study of patients, of doctors who are critically care trained and sit down with a booklet of waveforms that are printed out, and they're told, find the asynchrony. They miss 50 to 75% of those asynchrony events. So they can be kind of subtle. Let's see if we can find them. So I'm going to go by the ventilator breath phase. So ventilator breath initiation or triggering. So most commonly this is a missed trigger. And just for time, I'm going to pass on why it occurs, but we'll get to that a little bit in just a minute. But it can be excessive triggering. I have examples of each. Down at the bottom in the slide set, there are a couple of references that I put in here. This is a really good reference in critical care medicine. There's another one by DeWitt, I think also in 2014, which are just really good guides. It's a general understanding of patient-ventilator interaction. All right, so you have a 43-year-old female transferred to the ICU after having surgery. She's RAS -3, no signs of discomfort, and here are the 3 breaths that she receives when she's in the ICU. Which breaths, if any, are initiated by the patient? And I'm sorry for all the choices, but I put all of them up here. 1, 2, 3, 1 and 2, 1 and 3, 2 and 3, all or none. So the idea is to figure out which ones are initiated by the patient and which ones aren't. Because if you're going to look for missed triggers, you have to know which ones are triggered. So without spending too much time on the answers because there are so many choices, you're looking for which ones are triggered by the patient. You click
5 responses, 6 responses,
5 responses.
7 responses.
All right, I'm just going to show it up here. I think, so the answer was 2. Let's see. I don't even remember what 2 was. Well, the correct answer, I know. So the correct answer is that breath 1 and breath 3 are triggered. And the way you can tell that is because of the pressure dip on the pressure curve just before inspiration on those 2 breaths, or the flow increase just before the breath is delivered on the flow curve. So that's what you're looking for when you're looking for triggers. Ineffective triggers are most often occurring in the setting of auto-PEEP, whether you know the patient has it or not. The way to find it is to use an esophageal pressure balloon, or if not, if you don't have that, to look at the flow curve. When you're looking at the flow curve, flow towards the patient is positive, flow away from the patient is negative, and if the patient's wanting to get a breath, they're going to pull that flow curve towards the top. And so what I'm looking for are little notches on the flow curve or little dips on the pressure curve. These may or may not cause an actual breath to be delivered, and if they don't, then that's an ineffective trigger. So we're going to look for them on this patient with asthma, who is being treated for asthma exacerbation on the ventilator, no pneumonia, she is comfortable, has an increased work of breathing, has some nasal flaring, and her lungs are clear. The question here is, how many complete breaths are delivered? And I'm going to skip this one just for time. I think we're kind of tight. But just count the breaths on the bottom. 1, 2, 3, 4, 5, 6. There's 6 breaths. All right. So the next question, though, is how many efforts are there that are not rewarded? So how many missed triggers are there seen on this screen? So take some time and look at that and see if you can find them. Answers: A is 2, B is 4, C is 6, D is 8.
7 responses.
All right, so now move on. Let's see what the answers were. Is that?
Yeah.
I don't know what that means. I don't know what you put for the answers, but the ineffective triggering are denoted by the IT. So each arrow is an ineffective trigger. So you can see these bumps on the flow curve, positive bumps, that there is no breath delivered at that particular time. Those are ineffective triggers. Now the top flow graphic is showing you IEs. Those are incomplete exhalations. So this patient has asthma. They are having auto-PEEP. They are not exhaling all the way. They're trying to take another breath. The flow curve doesn't come anywhere back near to 0. And they're trying to overcome auto-PEEP, take a breath. They can't, and there's an ineffective trigger. So that's a lot of wasted patient effort. Makes them look uncomfortable. Their nasal flaring and other things like that. So it increases their work of breathing. They might get sedated more. That's the last thing they may need in terms of getting them off the ventilator, but it's what happens. So there's another form of triggering that is called reverse triggering. So this is a different phenomenon that I wanted to bring up because I feel like I see it every about 2 weeks when I'm on ICU service, and it's from entrainment or reverse triggering. These are the same thing, but they're called different names in the literature. It was originally described in patients with ARDS, but it's been more described in patients with severe sort of brain suppression, either through a brain injury or through sedation. And so in this case, this is a 43-year-old male who had ARDS due to pneumonia. He was on volume assist control. And what was happening is that this patient has an esophageal pressure balloon, and he's getting volume-delivered breaths, which are the second curve down is the volume volume curve. He gets a breath. Then what happens is there's a strong negative deflection in the esophageal pressure balloon, which means he's trying to take a breath. And a second breath is given, so the volume curve goes up, and then it goes up again. And so what's happening is that's like the double triggering, and it might look different on different ventilators. And this one, the volume curve goes up, and then it goes up again. Some of them reset, and it looks kind of like that shark fin look. But this is called entrainment. There's something that happens when patients are delivered a breath where they neurologically sense that, and then they start to help the breath. And if that occurs at the wrong time, the ventilator detects that as a trigger and gives them a second breath. It's a feature of brain suppression. It's common in deeply sedated patients. It's more common in deeply sedated patients. And sedating the patient will not make those double triggers go away. That's what's usually done, but it won't make it go away. This is a case, I'm going to kind of skip through it really quickly, but this is a patient who actually had out-of-hospital cardiac arrest, had prolonged CPR, was brain dead. They put a diaphragm transducer on the patient after the patient was declared brain dead as part of a clinical study. And he was having strong diaphragm effort with essentially this entrainment phenomenon. After the breath had been given, then the diaphragm starts taking the breath. It's considered almost like a reflex in a sense. So sometimes when you see this, you don't need to sedate it, because the patient's sedated already. All right, I know we're running very late on time, so I'm going to go quicker now. So asynchrony during flow is much easier, I think, to detect. You look at the pressure and flow curves, and it's usually in a patient that's on volume control. Volume control, you're setting a limit to what flow is given in a pattern. And in patients who are trying to take a breath with that flow limit, the pressure, if they're pulling the breath in, the pressure curve is going to be progressively more and more scooped, or what I call sucked down, for each breath. And if you're seeing those strong negative deflections, sometimes there are even negative numbers, deflections in the pressure curve, with breathing, the patient is really trying hard and they look like they're trying to breathe, but they're just not being rewarded by adequate flow. In this scenario, you need to give the patient more tidal volume, more flow, faster flow, or figure out why they have such a high respiratory drive. Asynchrony during cycling can be really hard to pick up. I think the esophageal pressure balloon would be especially helpful in that scenario, but it's not often available. Essentially, as a patient is done with the mechanically delivered breath and is about to exhale, either they've gotten too much, they want to stop the breath early, or they want more, and the ventilator switches to the exhalation mode and they continue to pull. That will sometimes pull a second breath and result in that double triggering. And that's called cycling dissynchrony. Patient A is resisting the end of inspiration at before the cycling time, and his airway pressure spikes in the second curve down, whereas patient B is pulling at the end of expiration for an ongoing duration of breath, and they have a lower airway pressure. All right, so what to do with this asynchrony? So my last slide says good luck, because that's essentially how I feel. So the first thing is try not to use a hybrid mode. If the patient is like pressure support with SIMB, if the patient's the breath pattern is changing with every breath, the brain center, the breathing center has a very hard time of keeping up with what's going on, anticipating the pattern, and synchronizing to it. So asynchrony is known to be more common in hybrid modes. You need to look at the waveforms in the patient and look for missed triggers. You have to look at the pressure and flow curves to look for missed triggers. They're easy to miss, and that can be a sign of auto-peak, which you need to address potentially as the underlying disease, or use higher applied peaks. Look for inadequate flow. That's easier to identify, and then change the flow rate or pattern. The problem with changing any setting on mechanical ventilator is that it changes other parameters of the breath that are being given, and you're essentially going to box yourself in sometimes to having a patient either have cycling dysynchrony or having flow dysynchrony. And it can be very hard to overcome. You want to sedate the patient, but sometimes they're ready for extubation, actually. They're ready to breathe, they're better, and actually consider extubation, see if they're ready. If the ventilatory drive is inappropriately high, like they're having double triggering, then those can be challenging if you don't think the patient is ready to be extubated. The main concern is to address underlying pain, anxiety, or other factors that are driving them to have such a high respiratory drive. They're going to continue to double trigger and have cycling dysynchrony if you can't address their underlying acidosis, secretions, pain, things like that. So you need to really focus on the underlying triggers rather than just tweaking the ventilator settings. Sometimes you need to tweak the ventilator settings by setting a higher trigger insensitivity, but that is usually done by RT before you're called. And look for entrainment, and I would say last, I put it at last on purpose, would be sedation. All right, and like I said, my last slide says good luck, because these can be challenging scenarios, and hopefully you can at least identify them better.